Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. We're going to continue in this session with the list of congenital anomalies affecting the gastrointestinal system of the newborn and infants. Our topic today is about pyloric stenosis, congenital hypertrophic pyloric stenosis. This diagram demonstrates the normal pyloric sphincter, and the picture B shows the hypertrophied pylorus leading to obstruction to the outlet of the stomach. Again, this is a hypertrophied pylorus leading to obstruction to the outlet of the stomach. The anomaly is a frequent one. The incidence is about 1 in every 500 live births, and it affects males more than females. Usually it starts presenting between the age of 2 to 12 weeks. Although it's a congenital anomaly, but it does not present soon after birth. Commonly starts manifesting in the second week of life, but the presentation may be delayed until the age of 12 weeks. The pathophysiology is hypertrophy and hyperplasia of the circular muscles of the pyloric region. The lumen of the pylorus narrows and lengthens, ضيق وتطول, and the gastric outlet is progressively obstructed. The clinical manifestations, as we mentioned, usually starts presenting at the second week or between 3 to 6 weeks, and the baby starts developing postprandial non-bilious, often projectile vomiting. So whenever he feeds, he vomits very soon. The vomitus is non-bilious. It contains the normal milk he is feeding. And what is strange is that the baby, soon after vomiting, he demands to be refed. And he is named as the hungry vomiter because he is not sick. He is having an anatomical obstruction. So whenever he vomits, he empties his stomach, he is hungry, and he asks for further feeding. What do we find in the baby on examination? Usually when the baby feeds, he develops upper abdominal fullness, the stomach fullness, and usually peristaltic waves may be seen progressing across the upper abdomen of the child, usually progressing from the left to the right side, which is parallel to the position of the stomach itself. This picture demonstrates the visible peristalsis. It starts from the left, ending in the right upper abdomen. This phenomena occurs when the stomach is full, soon after the baby feeds, just before vomiting. So the baby usually gives history of vomiting, which is non-bilious, soon after feeding. Gradually it becomes more and more projectile, and what is regarded as diagnostic is when we feel an olive-shaped mass in the upper abdomen just to the right of the right rectus muscle. If the condition is neglected and the problem is not diagnosed, the baby would develop weight loss and failure to thrive. We mean failure to gain weight. Because of the persistent vomiting, the baby may present in dehydration. This is what is called the feeding test to diagnose this condition. We keep the baby naked, we remove the dressing, and the doctor sits to the right side of the baby, and we offer him a feed. Soon after filling his stomach, the upper abdomen becomes full. Visible peristalsis may be seen progressing from the left to the right side. And soon after vomiting, usually the olive-shaped mass is shown. It is easily palpated in the right hypochondrium, just to the right of the midline. The olive-shaped mass represents the hypertrophied pylorus, It is olive in size, جد الزيتونة. It is freely mobile, non-tender. Usually it becomes palpable soon after the baby vomits. This demonstration demonstrates a neglected case, delayed diagnosis because the baby is severely wasted. He is having severe failure to thrive. When we offer him a feed, there is gross fullness in the upper abdomen with visible peristalsis progressing from the left to the right hypochondrium. There are characteristic metabolic changes that accompany this condition, especially they become more and more prominent if the condition is not picked early and not treated. Due to the persistent vomiting, the baby develops hypochloremic metabolic acidosis. This is due to the persistent loss of the hydrochloric acid present in the stomach secretions, so there will be loss of chloride and hydrogen ion ending in hypochloremic metabolic alkalosis. In addition, hypokalemia, potassium is present in the GI secretions all along, including the stomach secretion. But the hypokalemia that is seen in such condition is more exaggerated, and this is typically because the additional losses, the persistent losses of the hydrochloric acid from the stomach, ending in the state of alkalosis, will make the renal tubules to try to compensate for this alkalosis and hydrogen ion loss, so they work to secrete potassium in order to exchange it for hydrogen ion to be reabsorbed through the renal tubules. And this phenomenon actually is seen in any protracted vomiting at any age due to the persistent loss of the hydrochloric acid. In addition, such babies may develop hyponatremia because sodium is also present in the stomach secretion. So hyponatremia, hypochloremic metabolic acidosis, and hypokalemia are significant changes in such conditions. This is strep representing the blood gas analysis of the baby and the acid-base condition. So you can see that the pH is plasma pH is 7.52, which is alkalotic. This is high pH. You can see the comment of the machine. It is high because normally it is up to 7.42, as you know. In addition, the bicarbonate is high, pointing to a metabolic cause of this alkalosis, and the potassium is low, 3.4 will comment low, with a low chloride also 85 and low chloride level. This congenital anomaly may be associated with persistent jaundice due to the persistence of unconjugated hyperbilirubinemia, due to the more active intrahepatic circulation because the bowel is empty, so the bile that is secreted from the gallbladder is reabsorbed back to the portal circulation and back to the liver. Common association with alpha-1 antitrypsin, midgut malrotation, etc. The diagnosis is settled from the history, the time of onset of the problem, the type of the vomitus, and the presence of the visible peristalsis, and the diagnosis may be documented by demonstrating the olive mass palpable in the right hypochondrium. If we didn't feel the olive mass, the best diagnostic tool would be ultrasonography. Previously, they used to do upper GI series. We mean by it the barium meal study, but now it is rarely required because the ultrasonography solves the problem totally. What is seen in the upper GI series is in the ultrasound is we need to measure the thickness and the length of the pyloric canal, because the pyloric wall will be thicker than normal, and the canal would be longer than normal. So a thickness, a pyloric muscle thickness more than 4 millimeters and a length of the pyloric canal more than 14 millimeters is diagnostic of this congenital anomaly. As you can see here, these spaces, this is the pyloric muscle wall, which is thicker than 4 millimeter, and the dots represent the length of the pyloric canal, which is again longer than 14 millimeter. This is an ultrasonographic picture. Again, this is a thickened pyloric muscle thickness and a prolonged pyloric canal. Again, ultrasonography, this is a cross-section rather than a longitudinal one. Had a longitudinal one, then نشوف the stomach distended or filled with milk, and the pyloric canal is prolonged. Here, this is a cross-sectional picture, again demonstrating the thick pyloric muscles, and this is called as the bull's-eye sign. On contrast study, what is seen is dilatation and distension of the stomach with stasis of the barium inside the stomach, and then what is called the string sign, which is a thin line of barium that is passing through the narrowed pyloric canal. This is called as the string sign appearance. Another finding on barium study, in addition to the string sign, is the shoulder sign. Due to hypertrophy of the pyloric muscles, the barium will pass as a thin line along the pyloric canal. When it reaches the duodenum, because the pyloric muscles, the hypertrophied ones, they protrude into the duodenal bulb, so the barium will cover the protrusion, giving what is called as the shoulder sign. The initial goal of therapy is to correct any fluid and electrolyte imbalance. Nothing per oral should be given because it will be stagnant in the stomach. Continuous nasogastric suctioning to empty and decompress the distended stomach. And the definitive treatment is surgical correction after fluid and electrolyte correction. Fluid and electrolyte correction is mandatory because alkalosis will create problems during inducing general anesthesia. Thank you. So, Shabab, continuing with our talk about variable congenital anomalies affecting the gastrointestinal system. The most common type of intestinal atresia is what is called duodenal atresia. We mean by atresia total obstruction of the lumen of the organ. Stenosis means narrowing. So duodenal atresia has a prevalence of 1 in 10,000, which is again a significantly frequent anomaly. 25% of the cases are patients suffering from Down syndrome, so it commonly affects those children. It is a congenital obstruction of the second portion of the duodenum that happens due to failure of recanalization of the bowel during early gestation. The incidence, as I mentioned, 1 per 5,000 to 10,000 live birth. Association with trisomy 21. It represents a surgical emergency and typically presents within few hours after birth, very soon, within 2 to 4 hours after birth. The infant usually presents with clinical features of failure to tolerate the feed and bile-stained emesis shortly after birth. So he vomits whatever he feeds, and the vomitus is bile stained. Due to the proximal nature of the obstruction, abdominal distension is usually not present. And because it is regarded as a high intestinal obstruction, frequently we get a history of maternal polyhydramnios with such problems. So the presentation: early vomiting soon after birth, bile stained, the abdomen is usually not significantly distended. How to prove the diagnosis is by having a plain X-ray of the abdomen, and preferably to be done in the erect position. So this X-ray have got what is called the double bubble sign. Two gas bubbles are seen in the abdomen. The bigger one is the stomach gas bubble, and the second one is occupying the first part of the duodenum or the duodenal bulb. This is characteristic of duodenal atresia. Again, this is a double bubble appearance, and you can notice that the rest of the abdomen is not aerated because it is an atresia, so no air is passing distal to the duodenal bulb. This is the double bubble sign. Again, different pictures of the double bubble appearance here. Because it is in the erect posture, air fluid levels are clearly visualized, and the lower abdomen still is not aerated. The same applies to this picture. This is an ultrasound appearance, again showing a double bubble appearance. There is gas in the stomach and the other bubble in the duodenum, and no air further. This is a surgical emergency. Soon after stabilizing the breathing of the child and emptying his stomach, he should be submitted to surgical correction. As you have noticed, the list of congenital anomalies that we have mentioned, most of them they present in vomiting. So what are generally the causes of vomiting early in life? This list and the one following it is for browsing. You do not need to memorize them, but I wish that you get the idea that causes of vomiting early in life are numerous. Some of them due to gastrointestinal obstruction, and we have mentioned some of these conditions. Others are due to gastrointestinal diseases, for example, gastroenteritis, or food allergy, what we call the eosinophilic or allergic enteritis. Others are due to neurological problems, for example, hydrocephalus, leading to raised intracranial pressure and ending in vomiting. Meningitis, infections, meningitis, sepsis or septicemia, urinary tract infection, all of these infections, they may show in the neonate as vomiting. They may present as vomiting. Long list of metabolic diseases and endocrine disorders also may show as vomiting, urea cycle defects, enzyme deficiencies affecting this cycle, congenital adrenal hyperplasia, which presents as adrenal failure early in life, again may frequently presents as vomiting, galactosemia, enzyme deficiency affecting the galactose metabolism. Other conditions may be due to poisoning, for example, iron poisoning, vitamin intoxication, etc. When do we care about vomiting? What are the red flag signs of vomiting? If the vomiting contains blood, whether red or black in color, this is alarming. If the vomitus is bile stained, this is always pathological. And you can see from this picture what do we mean about bile stained vomitus. If the vomitus is projectile, forceful vomiting, again, it is pathological. If the baby is unwell, if he is looking tired, looking sick, toxic appearing, there is possible infection and sepsis, so definitely this is pathological. If the baby is failing to thrive or failing to gain weight, this is abnormal. If there is additional diarrhea, additional to the vomiting, if the abdomen is distended, this is abnormal. If there is a delay in the passage of meconium, which is expected to be done within the first 24 hours, and if it delayed more than 48 hours, this is definitely abnormal. And lastly, if the patient is dehydrated, surely this is a pathological. So the last part of our talk today is about intussusception. Intussusception is an acquired, not a congenital problem, and it is defined as telescoping of part of the intestine into an adjacent distal portion. So a more proximal part of the intestine is invaginated inside the distal part to it. So telescoping of one portion of the bowel into its distal segment, most commonly it occurs in the terminal ileum into the cecum. So the terminal ileum will be invaginated inside the cecum. It commonly occurs due to lymphatic hypertrophy in the Peyer's patches from a recent viral infection, and this infection could be a viral gastroenteritis or a viral respiratory tract infection. The peak incidence of this problem is between the age of 3 months up to 3 years, and this is the period for the idiopathic form that follows viral infection. If the problem occurs below 3 months of age or beyond 3 years of age, frequently it is not the idiopathic type, but it is secondary to a mass lesion that have dragged the bowel and created the state of intussusception. And the mass, it could be a Meckel's diverticulum, for example, it could be a polyp, it could be a tumor mass, etc. So the intussusception may end fatally if not diagnosed and treated properly. Shock or sepsis may be established within 12 to 24 hours of the beginning of the problem. And this problem occurs because the invaginated part, it drags with it part of the mesentery. With dragging the mesentery, it will compress the blood vessels in the mesentery, leading to impairment of the blood supply to the invaginated part, creating a state of ischemia. If not relieved, it may lead to gangrenous changes in the invaginated part, ending in perforation and peritoneal soiling and peritonitis. So how does it present? How do we suspect the problem of intussusception? The child may be having a history of a previous respiratory illness or a previous simple watery viral diarrhea. Suddenly he starts to develop episodes, recurrent episodes of acute, colicky, severe abdominal pain. So initially it is intermittent, recurrent, colicky abdominal pain, during which the child usually drags his legs, he flexes his knees and drags his legs to his abdomen. يضم رجليه على بطنه with flexion of the knee joints during the painful episodes. In between, after the subsidence of the colic, the child may return back to normal, comfortable, but with time the episodes become more frequent, and in between the child may remain sick, tired, and lethargic. So the child screams, drawing his knees to his chest. On examination, the examiner may be able to see a sausage-shaped mass in the abdomen. Initially, the child would pass normal bowel motion, the stool that is present below the level of the obstruction, but with time it will contain mucus and sometimes even bright blood, which is typically called the currant jelly stool, which stands current jelly مقصود بها من أنواع مربى الكرز اللي تكون هي glistening لماع أحمر لماع اللون مالها. with time the child may pass mucousy and bloody stool, bright blood in the stool, and with the progression of the obstruction, after he empties the part of the colon below the level of the obstruction, the child may continue passing only mucus with or without blood, without any fecal material. So at the end of the track, in between the episode, the child will be listless, lethargic, pale, weak, and he will not be passing bowel motion anymore. A full-blown picture of intestinal obstruction. Constipation, some mucus plus minus blood per rectum, abdomen would be distended, with the occurrence of vomiting. Initially, the vomiting is normally colored, but with time, with the progression of the problem, the vomiters would turn bile-stained. So our role is initially to start fluid and electrolyte replacement with monitoring of the general condition of the child, nasogastric suction to relieve the fluids stagnant in the stomach. Antibiotics may be offered, and the treatment is by reducing the intussusception, which is done either by closed reduction, which is either barium or air enema. Both of them, they are useful in the diagnosis and in the therapy of the problem. If not successful, then surgical reduction would be the solution. This diagram represents the process of the telescoping, of the invagination of the ileum inside the cecum. Again, this diagram represents the process of intussusception, where the blood supply will be impaired to the bowel wall, followed by ischemic necrosis of the bowel wall and perforation. Again, this is the invaginated part. The whole area will be ischemic and liable for perforation. Abdominal examination may be normal, or it may reveal the sausage-shaped mass of the intussusception. Urgent surgical consultation is warranted. Contrast or air enema can be diagnostic and therapeutic, but surgical reduction is indicated when the contrast enema is not successful. This is the typical currant jelly stool. You can see it's fresh, bright, fresh blood with mucus. This is at the end of the process. There's no fecal material, just the blood and the mucus. The plain abdomen in the erect position shows absence of gas in the lower abdomen. The ultrasound is very useful in the diagnosis of intussusception, and here it shows what is called the dot sign. هذه layers المتعاقبة surrounding each other of the intussusception. Again, this is ultrasound demonstration. Some people they call it the dot sign, some people they call it the donut sign. المهم الدونات كلكم تعرفوه فشي يشبه احنا بالعربي نسميه داطلي. It is the rounded donut shaped sign. This is a longitudinal picture showing what is called the pseudo-kidney sign of the intussusception. هذه successive layers of the intussuscipient bowel. So the diagnosis then is done by ultrasound examination, possibly plain X-ray of the abdomen, but a contrast enema would be both diagnostic and therapeutic at the same time. What do we expect to see in the contrast, or we mean by it the barium enema? Definitely. It gives the typical initially cessation of the barium column at certain level اللي هو level of the intussusception with cupping of the end of the barium column that تشوفوه concave مقعر. Then what is called the cold spring appearance, because a line of barium would pass between the intussuscipient layers of the bowel. This is again a contrast barium enema. The barium stopped at a certain level with cupping of the end of the barium, and the thin line of the barium column that is passing between the layers of the intussuscipient bowel. Again, the barium have stopped at a certain level with cupping of the end with this thin line of barium delineating the intussuscipient layers of the bowel. If we are planning to reduce the intussusception by the barium enema, then we need fluoroscopy to watch the movement of the barium forward until it relieves the obstruction, pushing out the intussuscipient part of the bowel with full barium column along the colon and flushing back into the ileum. In that instance, we can ensure that the obstruction have been relieved. So the management is by reducing the obstruction, either in a closed manner, which is by the contrast enema, or by the air enema. Both of them, they need fluoroscopy. Fluoroscopy, we mean by it continuous radiation to watch the movement of the line inside the colon. If it fails, then surgical reduction is warranted. But surgery is not warranted only on failure of the closed technique. It is sometimes contraindicated to try closed reduction. When would it be contraindicated? This is when the problem is lengthy. The diagnosis have been delayed more than 24 hours. Because within this period, we expect that there has been definite ischemic damage to the bowel wall, and there will be a great risk of perforation. So from the beginning of the colics until receiving and diagnosing the patient, if the duration was more than 24 hours, better not to seek a close reduction. So it will be contraindicated. Where else? If the patient is showing real signs of peritonitis, that means high fever, toxic, tense abdominal distension with rigidity, leukocytosis, all these parameters endanger the process of close reduction, because there is a risk of perforation and severe soiling of the peritoneum. So in the presence of features of peritonitis, better to follow IV rehydration and resuscitation, offering antibiotics and surgical consultation to clear the peritoneal cavity and keeping a drain, and later on radical surgical correction of the problem. So surgical intervention is preceded by IV fluid, antibiotics. If manual reduction is attempted during surgery, if there are ischemic changes in the area, they will not only reduce the intussusception, but they may need to resect the ischemic area and do end-to-end anastomosis. This is manual reduction during laparotomy. Manual, I don't mean closed. Manual, we mean during laparotomy. The area is still healthy, it is not necrotic yet, so they are attempting manual reduction. In conclusion, vomiting is a non-specific syndrome. It may accompany a wide variety of gastrointestinal and even extraintestinal disorders in childhood. Conditions such as mild gastroesophageal reflux may only necessitate reassurance to the family. but symptoms of bile-stained vomiting should prompt immediate referral to a pediatric surgeon. Associated fluid and electrolyte imbalances always must be considered when assessing a child who has a history of vomiting. Results of the history and physical examination, keeping in mind the nature of the vomiting, whether it is bloody, whether it is bile-stained or else, the age of the baby or the child, I mean by it the time of onset of the problem, at which age. It may help to determine the likely cause and the need for urgent treatment. Thank you.